The agenda of today's call is to discuss the way this industry is evolving and the way digital health is transforming in India, right? So we have seen that the pandemic has impacted the industry in a very bad fashion, but in some ways, digital health has been, one of the saviors for the industry. So the idea is to discuss today how do we move from innovative solutions to revolutionary transformation. India has already leapfrogged the world. If you look at the way India has adopted digital technologies, so we have seen how digital identity platforms like Aadhaar and digital payment systems like the Unified Payments Interface have transformed the entire industry landscape in India. We have seen in the last 1.5 years how digital health could also be transformed by leveraging similar innovations. So India has already embarked upon a journey to implement the Ayushman Bharat digital mission, which is going to transform the entire sector. And it is going to set the foundation for overall innovation in the ecosystem. So to discuss how this innovation is going to transform and how we are going to proceed, we have an eclectic group today. I'm very honored to moderate this session today, and talk to this group of extraordinary gentlemen that we have on the call today. So let me begin by introducing who all we have on the call today. So we have Dr. Emmanuel Rupert. He is the Managing Director and Group CEO of Narayana Health. We have Dr. Harikrishna, who is the Executive Director of Medicover Hospitals. We have Dr. Karthik Rajagopal, who is the CEO of Manipal Hospitals and is one of the veterans in the industry. We also have the pleasure of hosting Dr. Hariprasad, the President of Hospital Division at Apollo Hospitals. And we also have Mr. Harish Manian, who is the CEO of 𝐬𝐩𝐞𝐿, one of the foremost healthcare providers in the. And let me begin by asking Dr. Emmanuel, the Managing Director and Group CEO of Narayana Health, on how digital health is, transforming the way Narayana Health has targeted the market, and how do you see this market evolving in terms of the embracement of physical and virtual models by care providers? Dr. Emmanuel?
Yeah. We have been investing a lot in technology over the last 4 or 5 years, and we have a software development center, and we have more than 100 engineers working on that, and we have an homegrown hospital information system called the Atma. And even before the pandemic, we were just about to start rolling it out. And during the pandemic, since the hospital information system is cloud-based with an intuitive interface and scalable and a modular platform, built on the open standards, we were able to deploy this across the entire network within a short span of around 6 months. And that was the foundation for us to quickly transform certain digital initiatives which we wanted to take during the pandemic. Some of the things which we were able to do quickly was to immediately put up a virtual health platform in a matter of around 10 days. The moment the pandemic was, we had a lockdown, and we knew that that was the way to go forward. And because of the enablement and the integration of the healthcare solid platform which we had, we were able to seamlessly integrate the appointment schedulings as well as the payment platforms. And the physical and virtual schedulings were able to perform. You could either have a scheduling done either through the routine call centers or through the website or through an app which we were able to release very quickly called as the �NH Care app. So the doctor had a visibility of the entire scheduling across the physical and the in-person consultations as well as the virtual space. So he could plan his day ahead. And the problem for most hospitals was the walk-in patients. They do keep coming in as a walk-in. So we were able to encourage people to go onto the digital platform and make their appointment scheduling. And even if they had a walk-in, because of the pandemic, we never allowed any crowding inside the hospital. We were able to get an appointment for that particular day as per this time slots happen. And we let the people go into the hospitals at the desired time. So that was the most important thing. The NH Care app itself was enabled the payment gateways so that we would be able to do the queueless payment systems as well for availing services like the laboratory diagnostics and the other things which the patients normally go to. And the most important thing for us to do the queueless system was to have the implementation of the OPD EMR. So we were able to implement the OPD EMR, and we are almost 90% compliant to all doctors. And by the end of this financial year, we will be 100% compliant and will be completely digital and paperless in the outpatient department. So that was the first thing about the consultations. But then consultations doesn't end there. The diagnostics as well as the labs and everything has to work in a seamless fashion. So apart from the queueless payment systems and other things, we were able to integrate the entire diagnostics through the DICOM systems, whether it was ECG, ultrasound, or the echo into the PAC system, so the doctors could have access to it. And the labs where we implemented the auto certifications for the lab, so that the reports and the other things and the diagnostic reports we were able to generate within 90 to 120 minutes. So within the matter of 2 hours, less than 2 hours, the person could have a consultation, could have the lab reports, have a plan of care, and move out of the hospital. But we went a step further because we knew that most of the people were having an appointment. We started having a pre-consultation, questionnaire-based, and and history taking done by healthcare workers who were senior people who were assigned this job, and they were able to make entries into the EMR much before the patient came into the system, so that the doctor didn't have to spend too much time entering and making a lot of entries into the outpatient department. He only had to confirm or add or modify some of the things which was already done. And we also had a scanning system, so to scan all the old records and put into the system so that it was readily available for them. So we parallelly did the physical as well as the virtual system as goes. But in order, because the software development team was in-house, they could interact with the functional teams, the operational teams, and the doctors to need what they were. And we also developed apps from the usual diabetic apps and other things. For the 𝐸-ICU, we developed an app as an ADI, which is Atma applications for doctor insights, in which the real-time, the monitors could be seen by the parameters on the monitor could be seen by the admitting consultant care team, which he had formed. And he could also have visibility of all the lab reports and the radiology imagings, as well as he could put progress notes from a mobile app. He might be distant away, but he could put a mobile progress notes, and he could do ask for investigations, order for investigations, and also order for medications right with the touch of a mobile app, which is very useful and helped us to in a long way into managing patients, especially in the COVID. So you could have senior doctors monitoring a set of doctors who are working in the house and do this entire virtual platform. Virtual consultations also took us a very big step, because adoptions was directly proportional to the access to healthcare. So we've seen that a lot of people from areas which had inadequate or not so adequate healthcare facilities in that region, coming from very remote areas, reaching out to our specialists across our entire network because of the platform. The drawbacks were obviously some of the lack of digital literacy and also connectivity issues was an issue, but we are trying to work it out with the WhatsApp platform as well, so that the video based things are much more seamless than with the other platforms which we have been using in the past.
Thank you, Dr. Emmanuel.
Yeah.
If I may interrupt, let me I think take a cue from there and go back to Dr. Hariprasad. So, Dr. Hariprasad, I think what we have also seen is the pandemic has resulted in a lot of job losses for the overall industry, and we saw that a lot of temporary staff was let go in various industries. So, how do you think the pandemic has impacted the hospital and healthcare industry, and how have you specifically looking at tackling the situation in a way that business also doesn't get impacted, and there are no impact. There is no very little impact on the jobs.
As far as jobs are concerned, I think healthcare is one of the industries where more number of people are actually recruited into the system rather than losing jobs. So I think it worked in the reverse, and not only healthcare workers, as Dr. Emmanuel said, a lot happened and is happening on the digital side of the whole healthcare system. So we needed people to handle the digital part of it also. So I think it's healthcare is one sector which did not let go of people, but actually started recruiting people for the new forms of models of care that evolved during the pandemic. There was always before the pandemic there were two types of divides. One was the geographical divide where people had to travel long distances for healthcare and they could not have access close by. And the second is the financial divide, which is people could not afford some of the advanced care in the larger institutions. Now, what the pandemic has brought in is the digital divide, and I think the digital divide is something which needs to be bridged immediately to maximize the impact of the benefit of the pandemic, if I may call it so, because digital literacy and connectivity, as Dr. Emmanuel said, need to be overcome before the entire potential of the digital healthcare platform is actually leveraged. And I think, as far as jobs are concerned, healthcare is on the right side, and we've actually healthcare sector as a whole can be really proud of what it's done during the pandemic and what it continues to do. And as you would know, this particular Omicron wave, much more number of healthcare workers are impacted, and more number of people are actually infected from amongst the healthcare workers. Despite that, I think the healthcare sector has stood up to the challenges both in the public and the private sector. Every single institution, doctor and healthcare worker, and everybody needs to be proud of what is being done by the healthcare workers during this period.
Thank you. So I think that's very relevant. I would want to ask Dr. Karthik in terms of what is unique about your operations post this pandemic, and how are you gearing up for the changes moving forward?
Thanks, Anurag. I think for us, it's been, post-pandemic, we realized that the patient base is one large heterogeneous base. Earlier, we thought we'd, group them into homogeneous bases, requirements are similar, etc. And that's, I think, been a big revelation for us. And when you actually club digital health, two people coming for the same procedure or same ailment might have very, very different needs outside as far as administrative and management perspective is concerned, and that's where we've actually gone ahead and looked at it. And if you really it's actually been a number of services, and I think Dr. Rupert spoke about that. Taking over from a queue from hospitality and airlines, we've shifted a lot of services to be completely under the control of the patient, and we've actually launched. And with that app, if you really look at it, the patients can fix their appointments, be it video consultations or face-to-face. They can download their reports, they can make payments, they can book their preventive health checks, etc. See, whatever services to which they actually needed to depend on the hospital, much of it has actually gone ahead and shifted across, to the patients. The control is in their hands right now. They can reschedule their appointments. They can, kind of go ahead and get everything that otherwise they would have actually depended on the hospital for. Digital health obviously is going to become a big reality, in India, and I think that's something that we, went ahead and realized. Therefore, a whole lot of investments. Earlier on, we thought FY25, FY26 would be when we would actually look at being completely digitized. But right now, there is a huge sense of, acceleration around, and large parts of our, operations are now getting digitized. Therefore, technology which was there, which was never really used, is now getting used significantly. We get a large number of patients from across the country, specifically the east and northeastern parts of the country, etc. That's where the lockdowns and the rest of the restrictions and movements has gone further in us going and quickening the adoption of digital technologies. So a number of our digital consultations now happen from parts of the country which are not our natural markets. And the other big thing is the at-home monitoring. And that's where I guess technology has really, really played a big role in terms of going ahead and getting this at-home monitoring vertical a lot more mature than what it was earlier. So therefore, a lot of our monitoring post a patient completes a surgery, etc., and goes home. That's actually become a lot more mature. So our ability to actually track them through their post operative phase has become a lot more robust right now than what it was earlier. Earlier it used to be physical interfaces. Digital has definitely helped us actually bridge that gap, and therefore in the comfort of the patient's homes. See, for many things, the patients need not really come to the hospital. One of the things that we realized was post-surgery, post-hospitalization, etc., for routine checkups, they did not come to the hospitals. And to that extent, our digital portfolio has really matured. So these are probably the 3-4 things that we've actually gone ahead and done in the post-pandemic phase. That's probably very, very important to us.
One follow-up question which I had related to what you just spoke about. There have been some changes in the way patients have reacted and adopted digital. There has been a difference in the way doctors have reacted to teleconsultation. What's your sense? Some of these changes, are they permanent, or is that a temporary phase that we are going through and people will go back to offline consultations, and is that something which is going to be permanent going forward?
See, Anurag, if you look at the traditional consumer buying behavior cycle, there is an innovator on one end and there's a laggard on the other end. So the innovators and the early adopters from the patient base have already started to go ahead and look at digital health, in a big way. And from a clinician perspective, obviously there has been a forced adoption, because in the absence of real data and analysis, etc., it's just a 15-20 minute conversation with the patient that actually presumes the largest part of the diagnosis that is going to go ahead and be made. And therefore, certain clinicians could be, pretty much risk averse into going ahead and making those diagnoses in those 10-15 minutes in the absence of data. So in the short term, when there are lockdowns and the pandemic is at a very, very enhanced phase, probably some of the clinicians in certain specialities could go ahead and opt for video consultations. But in the medium term, as the pandemic wanes, etc., they would prefer actually going to go ahead and look at physical consults from a consumer behavior cycle point of view. And I think some of the a large part of the patient base, in fact, do feel hospitals and healthcare is still a touch and feel industry, and therefore the right diagnosis is actually going to be made when I physically meet the patient, doctor or the consultant examines me. So for that set of patients, it will still take a while for them to actually go ahead and adopt to a fully digital mode. So therefore, as you start to go ahead and look at short-term, digital health will be adopted both by doctors and patients. There would be an extent of force in that. We've seen in our hospitals, and I'm sure it's similar in the other chains as well, that as the pandemic wanes, we've started seeing patients come back to the hospitals, in a rush. And when actually the number of COVID cases start going up, they start to go ahead and stay away from the hospitals. But in the long run, I think if the a doctor has the confidence of the data behind him or her, they would actually go ahead and look at more specialities coming into the net of digital healthcare. Similar with patients, etc., as they see more and more of their tribe actually going ahead and getting consulted over the digital and diagnosis made a right, probably a larger mass will actually go ahead and come. So to reiterate, in the short run, there could be a forced adoption, and from the clinician side, from the patient side, it could be the innovators and the early adopters who probably move into digital. In the long run, I guess both these communities will move into digital health. For the clinicians, data is very, very critical, and for the patients, it's the confidence that all organs in the body can actually be diagnosed right. Or complications in all parts of the body can actually be diagnosed through digital health. So this is where we are.
Great. That's very helpful. So I wanted to ask a related question to Mr. Harish Manian. Mr. Manian, you have been running the show very successfully. But what has been your feedback from the ground in terms of feedback coming from the doctors? If they require any incentives to adopt teleconsultation, have you seen any barriers to adoption? What has been the general trend and feedback from the doctors?
Good afternoon, everyone. I think it's really great to be part of this panel, and I'm really happy to be part of this panel because a lot of people I know personally. and thanks for having me. I think it's absolute pleasure to be there. Thanks, Anurag. Uh, Having said that, I think we had a great run, to be very frank. We are the youngest kid on the block at this stage, very young organization, 2 years old. But the doctors who are with us have got tons of experience to work with us. So technology adoption was always a challenge. But from the day one of this organization, I think technology was the fulcrum under which everything was functioning. So we were sensitized in the way the technology was deployed in all the points, especially at the clinical areas. And we didn't find too much of difficulties at this stage. The reason being that this was a reversed adoption from the customer's end. When customers started asking for how we can reach out, as Mr. Karthik just now mentioned, that many people have adopted technology, and some statistics are suggesting that the adoption of technology at a pace which was earlier, which was 5 years ahead of technology people have adopted in the last 8 months to 10 months. That's one. Second, and the technology adoption has been highest in the rate in the age group of 50 plus, which was in the range of 20, 25, and 30, which is considered to be the group which adopts technology. And during pandemic, what has happened is 50 plus has adopted more technology compared to what the others have done, because others are already known about it. With that being in place and technology platforms which were available, and it's not about our hospital, every hospital has deployed chatbots and teleconsult platforms. Everything was done overnight, and many of them had it in place and was not utilized. So this became a forced utilizing platform by every individual, because they didn't want to lose customers, and everybody realized, especially doctors realized, that they have to use this, otherwise the people might go to some other competitor for their help. And pandemic was a big leveler. I would always say this was a big market leveler for everyone, to make that whole platform, make the whole market even Steven for everyone. The reason is that whoever could help a customer during this particular period, maybe technology, no technology, or giving them beds, the people would have changed loyalties during this time. And that has happened. And there are data to prove in many markets that how things have shifted. So I mean to say, I think there was no great push required, but yes, there were incentives in the sense our routine charges were levied on an online platform. There were free consultations who were also available for people who are subscribed to certain models. So we had publicized certain models, which was in favor of doctors also, because they're spending time at the end of the day, and they need to be leveraged financially as well. So that worked well.
I think let me ask a follow-up question on this itself to Dr. Harikrishna from Medicover Hospitals. Now, Dr. Harikrishna, I think we heard from Harish how he feels about this. But what do you feel in terms of are we looking at, when it comes to future, are we looking at bringing in a new era of packages, new care plans, new value-based care models? Are you looking at some disruption in the industry in terms of insurance as a model? Do we also look at in future, let's say OPD insurance getting fast tracked in a way in the India market? What's your sense on the entire insurance piece?
Hi, thanks Anurag. Just a small correction. I'm not a doctor. I'm just Hari Krishna. Yeah. Well, good morning all the panelists. It's indeed a great pleasure to be part of such team whom I know most of them personally. Thanks. So coming to the question, it's actually good that a lot of people are becoming active and aware about the health insurance, because as you know, when it comes to health insurance, India is already a very, very under-penetrated market. Most of the people are either pay through their out of pocket, or it could be government or some companies who sponsor. When it comes to pure insurance, it is actually less than 5-6%. And in the corporate hospitals also, even today, it's about 20-25% of the patient occupancy is taken by insurance, which otherwise should be at least 75-80%. So, but with the onset of pandemic and a lot of awareness, a lot of importance is being given to health now, people are going and opting to pay for a lot of insurance plans. So when people are moving towards insurance, definitely the insurance companies, which have already formed a kind of a cartel through GIPSAs and all, have come up with a lot of packages. Some of the corporate hospitals could get the best price, some of them are still trying to get it in the due course of time. Coming to when you go into insurance, when it comes to insurance and value-based care or quality care doesn't go well. Most of the corporate hospitals, most of the hospitals in India definitely give a lot of importance to value-based care or quality care, which has always been part of the culture in the Indian healthcare system. With the pandemic bringing awareness among people, it will only accelerate our efforts to ensure we are always striving towards best patient care and outcomes. Coming to flexibility on packages, so definitely when the more penetration, there will be requirement to float more packages. More packages, there would be some disputes, some disagreements, some expectations and all. But as we move forward, as the patients start routing their healthcare to be channelized through insurance, definitely the systems will evolve. Most of technology will come into place. A lot of right sizing of manpower will happen, which is otherwise done, taken care of a lot of people in a healthcare delivery. So whatever which is going to come post insurance era, I think it should be good for the corporate hospitals and for the general public as well.
Great. And just a follow-up question in terms of infrastructure availability. I think what we have seen is that tier 3 towns especially have struggled with lack of medical infrastructure. So what's your feedback or suggestion? How can we collectively improve the infrastructure available at the ground level, whether it's coming from the government or from public-private partnerships? What are some of your suggestions on how do we improve the medical infrastructure in tier 3 cities, villages, and maybe even some of the smaller towns that we have?
Yeah. So it's actually a relevant question for us. And a healthcare operator who is operating more than 70% of our available bed capacity is right now we operate in tier 2, tier 3 cities, which has really come handy during the pandemic time. That we could manage and treat our patients in most tier 2, tier 3 towns in India. We operate 20 hospitals, of which 17 are part of tier 2, tier 3. There are quite a few challenges when you go and operate in tier 2, tier 3 city. One is getting the doctor group. Basically, if you are a qualified doctor, most of them would prefer to go to a metro city because of various other facilities which are associated with the metro city, which is there, like whether it is a good school or a good nightlife or whatever which is required for a consultant who has passed out his post MD and then he want to definitely stay. So this is one of the challenge we had, and then a lot of qualified manpower. Basically, the expectations in a tier 2 is much more than the metro town because people expect you to deliver the similar kind of service at a lower price and much more better way. So this was one of the challenges which somehow we could manage by pooling doctors who are looking to relocate to this part of South India. So we could get them, and we are successfully running. And especially during pandemic time, which is during the wave 1 and wave 2, we could save maximum lives because we could save the time. We could give the quality healthcare in their own town. So there are certain things which we need to take care very well. One is training, one is orienting the employees based in tier 2, tier 3 to their level what we offer service in the cities and towns. And we also have to ensure the supply chain needs to be very, very streamlined and on dot, so that you ensure that the delivery of the medicines or consumables on a right time. So again, giving integrated approach with a larger hospital and the tier 2, tier 3 cities will definitely help the hospital in the metro town as well to get the patients which cannot be treated in the small facilities. So all in all, every corporate hospital, every healthcare sector, every healthcare organization should really strive to build their infrastructure around tier 2, tier 3 cities is what I would like to tell based on the experience and success we have seen.
Great. I think you made some really great points. So let me ask this question to Dr. Hariprasad as well, right? In terms of suggestions for improving infrastructure at the ground level. Plus, also, I would want to hear from Dr. Hariprasad if he feels that technology is going to create pressure in terms of the way the insurance companies are reacting and the way pandemic has resulted in a larger number of claims coming in. So do you think technology is going to be a barrier? Will you be disincentivized to be more transparent, or is it going to be the other way around where you'll be more proactive in sharing data and more comfortable in sharing data because it is available through a digital highway?
Let me answer the second question first in terms of the pressure on healthcare institutions because of the digitization. I mean, we genuinely believe it's a very good thing to happen because I'm sure that a majority of, I mean, all of us present on this platform and all the large hospitals believe in transparency. And one of the main problems that we face today is the perception of the general public which has been created is that there's so much hidden behind the wall and which the people do not know. And I don't think any one of us want to hide anything from the patient. We are all extremely transparent. It's only that probably we could take the blame of not having enough focus or time spent on creating that transparency. But once this digitization happens, transparency will follow, and I think it's a good thing for the healthcare sector because the trust in the sector would actually improve with the transparency that comes in along with it. So that's as far as digitization is concerned, and with insurance and improving digitization in terms of the processes and systems, I think the patient is the biggest beneficiary at the end of the day, and that which is always good. I mean, all the healthcare institutions always place the patient at the center of everything that they do, and anything which happens good for the patient is good for healthcare system. So the insurance, whether it's packages, whether it's digitization, whether it is online, right now we have a lot of time is lost in pre-authorization, and in terms of final bill authorization, patient has to wait. Now, once it becomes digitized and there's seamless flow of data across the insurance and TPAs and hospital healthcare providers, it's the patient who is the beneficiary. So I think in this whole context, it's a very good thing that's happening, and it will help both the patient and the healthcare providers in terms of the speed with which we can deliver, the efficiency with which we can deliver services. Now, regarding Tier 2 and Tier 3 cities, I said at the beginning itself that one of the biggest divides that we have is the geographical divide, because India is a huge geographical expanse with islands of excellence in an ocean of inadequacy. The islands of excellence, all the hospitals which are on the call today, are all islands of excellence, majority of which are situated in the larger towns, larger cities, mainly the metros, while a large part of the Indian population lives outside the metros in the villages and in the Tier 2 and 3 cities. So reaching out to them is a very important aspect of it, and the pandemic has given us one tool of reaching out to them, which is the technology part of it itself. Telemedicine never existed forever in this country, at least for the last 20 years. I know we've been doing telemedicine. But it's only in the pandemic that pushed the government to bring out some rules and regulations and some law about telemedicine, which is relevant to the healthcare population, healthcare providers. So technology is one tool which can bridge this geographical axis. And second thing is, I'm sure a lot of us, we started many years ago, almost 14 years ago, to move into the Tier 2 cities. Essentially, into Tier 2 and Tier 3 cities, primary care and secondary care are relatively well served. What is not really present is the tertiary care, which the people do need, and they tend to travel to the metros for care. So what we did was we actually got in the hospitals which were providing mainly the tertiary care, and which were actually supplementing the care which existed in the Tier 2 and Tier 3 cities. And I must say that we were extremely successful in that. One challenge which we will face is it's easy to invest money, create the hospitals, create the buildings, get the machines and stuff like that into the Tier 2 and Tier 3 cities. But the real challenge is the human resources. Good human resources are still required and are in demand in the metros, where life is more comfortable for them in the Tier 2 and Tier 3 cities. So I think one of the big challenges which one needs to solve before getting into creating the infrastructure is to be able to get the human resources into those places. And we've been successful being a large group because we have our own postgraduates who are passing out and who get a stint in the Tier 2, Tier 3 cities before they come back to the metros. So I completely agree that Tier 2, Tier 3 cities need the infrastructure, and for infrastructure to come in, I think it's the human resources which dictate the bottom line.
Great points. Let me ask Dr. Karthik as well this question on what is his take on the entire commercial aspect of it. What are some of the suggestions to make it work, both for the citizens and for the hospitals?
Thanks, Anurag. And I think, Dr. Hari had spoken through very, very correctly that, one of the other panelists also alluded to this, that, private sector has actually gone ahead. The healthcare sector has gone ahead and taken quite a bit of battering, from the public in terms of is it for-profit hospitals, unnecessary procedures, etc. I mean, I think the misnomer is there is a huge fixed cost that every hospital actually kind of incurs. So when you're really looking at some of these schemes, etc., until and unless there is a price viability, I don't think private hospitals, because a huge amount of fixed costs that we're incurring, the equipment, even the digitization, the kind of capital expenditure that hospitals have and incur is quite large. So therefore, when somebody is actually going ahead and underwriting, a health expenditure, unless the prices are fairly viable, it probably will be a non-starter. And then is when empanelments for all quality institutions, branded healthcare institutions in the country, then becomes a big issue. And therefore, that is something that is primarily should be given importance, and we need to go ahead and look at that. Because, see, I'm not saying economics is the start point of every relationship, but it is important that we actually start to go ahead and look at that very closely before we start to actually go ahead and become ambitious about partnerships like these, because it is bound to fail at some point in time. They may be forced acceptance in the beginning, but ultimately, it's not going to go ahead and succeed in the long run.
Thank you, Dr. Karthik. A related question which I wanted to ask, Dr. Emmanuel, I'll come back to you on this. So I think my sense is during the wave 1 of pandemic, hospitals suffered huge losses. Then we had the wave 2 where the hospitals were overoccupied. So what has been the overall financial impact of the entire pandemic situation, and with the wave 3 now spiking? What's your take on the overall situation today? And is there anything that hospitals can do? Is there anything that can be done by the government to make sure that this is a sustainable model, and we will not have some players falling out?
Yeah, the first wave, the main the losses were mainly because of the severe lockdown. And there's just no way patients could come to the hospital for any kind of help unless it is in a dire emergency. That was the severity of the lockdown that was experienced by the whole country. But then the whole world was learning how to handle the COVID pandemic, and that was when the lockdowns were all relaxed and things started moving in the right direction. But unlike just like Karthik said, we have huge fixed cost, and there is no way you could let go of the manpower and staff and other things. So that led to the significant losses in as far as the wave 1 is concerned. And the wave 2 definitely had a lot of stress because of too much of there was a lot of overoccupied beds. But at the same time, it also put a lot of pressure because some in certain states and certain governments did take over partially the ICUs and the beds of the private hospitals for the COVID care, and paid at a very nominal rate, and that was also putting a lot of pressure on that. And I had to add to that, the ALOS of the COVID patients were also quite a bit. So that puts if you can explain, it's not very simple to put a number to it, because it depends upon the spectrum of care you did in that particular hospital, whether you concentrated significantly on the secondary level care, because most people postponed all their electives of the secondary level care. But for hospitals, we'd had a right mix of oncology and things which could not be postponed. All were able to overcome some of the revenue, at least to a large extent. So if you really look at it, it all depends entirely on the spectrum of the clinical work the particular hospital did. And some were able to meet their, the expected revenues, which was there, and some probably maybe had around 20% or 30% less in that. But overall, there was an impact, whether the hospitals were occupied because of the shift completely in the spectrum of work. There were certain hospitals which did a very high-end, quaternary work, which was there, which even though the occupancy wasn't that great in that particular segment, but by the sheer the nature of the quaternary work was able to sustain it during this period of time. The way the third wave, going by how it has been panning out in the rest of the world and how it is going to be there, it is going to come in a major way in India. We have already started seeing that asymptomatic people coming for elective work in other departments are to the extent of 25 to 30% turning out to be positive on a routine COVID testing. So that is going to impact the number of people which will always get into the hospital for any kind of a treatment. It's going to be impacted. But considering that people have been vaccinated because of the vaccination program the government has launched, and also the hesitancy is no longer there, unlike in the first and the second wave, I think we should be in a position to weather the storm of the wave 3 and be able to go there, because we have also learned a lot in the first and the second wave, and we know how to segregate work, coexist with the COVID and the non-COVID work. So, segregate staff for both these work. So we are able to handle both this, effortlessly, and with the people also accepting that it is going to be an endemic kind of a problem. I think we should be able to weather the storm of the wave 3.
Thank you, Dr. Emmanuel. I just wanted to come back to the theme that we have today, right? So we are talking about how are we going to move from innovative solutions to a revolutionary transformation. So we saw that when India leapfrogged the world in terms of payments getting digitized, we have been able to prove to the world that small innovations or large innovations can actually create an impact on the ground. So I think one of the major innovations that have happened recently is the Ayushman Bharat Digital Mission, or the erstwhile National Digital Health Mission. So wanted to ask Harish on this, that we have the highway getting created, and I know it is early days now, but what's your take? Is ABDM or NDHM going to create a similar impact as what was created by UPI in payments, or is there any other bright idea that you have on how technology could transform the entire sector, right? Is there something specific that you feel India can do to transform the sector, not just to innovation in bits and pieces, but to an overall transformation?
Anurag, my view on all these transformational policies coming from government is, I think a lot of private sector is still not participating in it, to be very frank. I think it's all loaded towards what the marginal healthcare providers are doing at this stage, especially towards the government side. And government, I think, primarily serves a lot of underprivileged people across India. If private sector has to participate, as Dr. Hariprasad mentioned, I think it has to be reasonably lucrative for everyone to participate. And the model should at least cover the fixed cost of an organization so that you don't bleed while treating the patients. And I will take an example of what the Tamil Nadu government does actually for transplants. I think it's a very specific area and very niche services. Rest of the governments across the country gives the least amount of money for transplants, and whereas Tamil Nadu government gives a lot of amount for that. In fact, liver transplant, they give almost 24 lakhs. But to get that money, it takes quite a lot of time. That's one. Second, I think with that amount of money, people are incentivized to do work even if there is a delay. So there is a catch in this. And if there is a value-wise, if it is not going to be attractive for larger people to participate, any program may not succeed actually. Because still your 70% of Indian healthcare is delivered by private sector. And if they are not onboarded with any schemes which government got to launch, even if it is technology-driven or it is by any other financial means, it's not going to be fetching the right kind of impact what you want to measure out of it. I think so. It's very important that all of us actually, lobby for getting a right kind of a, pricing points for healthcare sector. And the irony is one of the largest payers in healthcare today is CGHS, and their prices are ironically 2004 numbers, which is almost like 2 decades away from where we are sitting today. And that's the pricing which they follow. So there is transformational change which has to happen in the healthcare sector to ensure that we come up to speed. When the economy has grown up by maybe 20% in the last 20 or 30% upside in the last 2 decades, still we follow the pricing in government sector in many of the areas which government provides it at way behind. So these are things which government also need to take cognizance of. And in fact, we are very gung-ho about the fact that government has allocated 1.6% of GDP this year. It's been a very fantastic approach by the government. But I agree to that. It's a good move. But having said that, where is that money going? I saw the Shashi Tharoor's dissection of 1.6 crore, 1.6% of GDP. And in fact, it shows that it is actually gone reverse. So we are not allocated enough in this budget itself. So I don't know. It's all I feel. I think still there is a lot of seriousness to come into healthcare. I thought people have woken up after this whole pandemic, but there is a lot to be done. This is not the budget allocation for anything, because if government has to participatively bring private sector into play, they need to do much more in terms of getting people on board, getting the pricing right, getting the technology adoption to the next level. And of course, we also have to realize that healthcare is not the company which has adopted technology at the pace which other industries have done. We are just doing it at this stage because there is a push, there is a demand. And if given a choice, our doctors will go back and start writing prescriptions actually. But we need to push them and keep them enticed with the whole thing. And with the schemes from the government, I think depends primarily. I'm telling you, nothing works better than the pricing. If the pricing is at the right sweet spot, things will move faster actually.
Yeah, some great points there. I wanted to ask this question to Dr. Hariprasad as well, because Apollo has been one of the early adopters and they have been trying to integrate with ABDM as well. So what's your sense, Dr. Hariprasad? How are you reacting to this entire digital health ecosystem getting created initiative? And are there any specific plans to leverage ABDM going forward?
I think it's a great move. There's absolutely no question about it in terms of the value it can create, because right now each hospital has it's completely a individualized phenomenon. Now, if you all get onto a common platform and if data is collected in a proper manner and it can be analyzed and it is collected in a manner where it can be utilized, I think it would do a lot of good to the country. In terms of epidemiology, in terms of research, in a lot of other ways, and also in terms of understanding the disease burden of the geographies and understanding what is to be done in terms of prevention. So a lot of things can come out of the data which is collected in a proper manner. But one of the most important things which need to be addressed and which we've been talking to the NHDM is about the safety of the data, and whom does the data belong to. Ultimately, we all believe and we all know that the data ultimately belongs to the patient, and we need to make sure that the data is protected and the patient has the right towards the data, and there are proper consents put into place, and healthcare institutions don't become liable for joining onto the National Health Digital Mission platform. So there are a lot of questions which need to be answered before the mission is actually rolled out and all of us are able to get onto the platform. But once these questions are answered and solutions provided, I think it will be a great move for us to move on to this platform, and the country will benefit tremendously. And when I say the country, it's ultimately the individuals within the country which will benefit the most.
Absolutely. I think what we've also seen is there are a lot of startups that have registered on the NDHM sandbox, and a lot of startups want to create compatible applications, innovate around the data, which is obviously going to be anonymized, but it will lead to a lot of innovation in the market. So let me just ask final question to Dr. Emmanuel around the same topic. Dr. Emmanuel, you have been doing a lot of work around digital transformation, and Narayana has been one of the front runners in adoption of technology. So what is the next big idea that you feel can be adopted in terms of digital transformation and how it will impact the country?
Yeah, I think like Dr. Hariprasad had said, if the overall health of the nation has to be improved, then we need to have work on data and needs to be looked at it in a proper manner, because every state and every region within a state has got different needs and different requirements, and we do not know exactly what is that. There is a lot of surveys coming out, the health surveys and other things, but it is not so granular to the point of coming out to what is the disease burden in all the things. And we should not try to fit the entire country to one kind of a requirement, because we have seen that all our hospitals have flow of patients from the east. Not that there is lack of infrastructure there, but then there is infrastructure that is more is needed, and only the tier 1 cities there is got the adequate infrastructure. Then the more interior, the tier 2 and tier 3 there, compared to the tier 2 and the tier 3 in the south, is far inadequate compared to what is seen there. So I think we need to make any kind of a digital mission which we have, it should include the entire length and breadth of this country, and it should make them completely inclusive for them. And we were very surprised to see that our virtual platform, when we looked at it, the adoption, we thought that adoption would be maximum in Gurugram, but we didn't see that kind of an adoption in Gurugram, because all of them had access to healthcare. They could get into a car and just drive and get into any kind of a in-person consultation. But the adoption surprisingly was from Northeast and from the interiors of West Bengal and from interiors of Central India. And that was the adoption was very high from there. And we as usual, we expected adoption in the southern states, and which was always there. And we also never saw any kind of adoption in Rajasthan and Gujarat and that kind of a thing. So it is so heterogeneous and so different. The needs for everyone is so this one, and the disease burden for every state is also extremely different. And we need to we need to get everybody on board. Like all the other panelists have told, it should make meaning for everyone, not only the government but also all the participative people in the private has to get into the bandwagon, get the data. Only when we collect data as a whole, we'll be able to come up with comprehensive care plans, what is required for every region, and we need to take it forward from there. Right now, we have absolutely no visibility as what is the requirement for each and every, either the NCDs or the communicable disease, or what is the disease burden, what is the requirement for deep disease burden in the congenital heart space, or any kind of a thing. We have this one. We did a data collection over such a long time. The paper was coming from AIIMS, and we've seen that most of the people, at least 75% of the people, had access to a congenital heart program in the southern India. At least 80% of them had access to care within a year of life, while the number was not even 17% in the northern states. So this came out because so many people participated in this and came out with that. But I think we need to, a lot of startups will come in, but then a lot of people will keep working on this. It all has to get integrated, and it has to be inclusive for the entire country for us to come with a solution which will be meaningful for the entire nation.
Thank you so much. I think you brought in some great insights from the ground and some great practical experiences. So we have come to the end of the 1 hour that we had budgeted for, and I'm sure all of us have many more questions which you wanted to discuss. So maybe I'll request Voice of Healthcare to organize another panel discussion where we can take the discussion forward. But today it has been an extremely enriching session, and I thank all the panelists for their valuable insights and sharing their feedback and suggestions on how innovation could be taken forward and transforming the entire country. So thank you once again for joining this